the Africa Health Research Institute in Durban. And I think he's got some very exciting data he is going to share with us. So Thumbi, thank you very much for being here. Thank you.
Thank you very much, Clive.
Yes, we can hear you. We can hear you.
Thank you. Thank you very much. I appreciate the introduction, and thank you for inviting me to this wonderful session today. I think the talks have been excellent, and I just also want to acknowledge your contributions to the field over many years. I think you have played a really significant role in making sure that we excel in this kind of work in Africa, and so thank you very much for your contribution. I'm going to talk about a combination immunotherapy study that we have been doing in Durban, South Africa, towards an HIV cure. And this will be the outline of my talk. A little bit on the need for an HIV cure. I think most people are familiar with this, so I will not belabor it. And then I'll talk a little bit about the current strategies that people are trying to see whether you can achieve an HIV cure. And then I wanted to discuss a cohort that we established more than 10 years ago called the FRESH cohort that is the basis or has become the basis for the clinical trial that we subsequently have done to try and see whether you can achieve an an ART-free control of HIV using an immunological intervention. So this is data from KwaZulu-Natal, where I work. This is from Mkanyakude district in northern KwaZulu-Natal. And what you can see there is that you have a very high burden of HIV infection. If you look at that age group, 25 to 44, you see that 40% of men and 60% of women are living with HIV. So this is a huge burden of HIV. These individuals will have to take antiretroviral therapy for the rest of their lives in order for them to be healthy. And if one looks at HIV incidence, you can see again that although we have made tremendous progress as a result of antiretroviral therapy, where incidence has been declining for almost 2 decades now, we missed the target for 2025, almost certainly, for new HIV infections. So the number of new infections is not going down as fast as we would like. And so this means that there are more and more people getting infected with the virus, and we again need to do something about those people as if you're going to have an alternative to lifelong antiretroviral therapy. So I think, again, most people maybe in the audience understand this graph where it shows the life cycle, or rather the trajectory of viremia in somebody living with HIV, where you have undetectable viremia if somebody is not on antiretroviral therapy. But as soon as you go on antiretroviral therapy, within a week or two, maybe a little bit longer, the viral load becomes undetectable, and it remains undetectable as long as you're on antiretroviral therapy. But once you interrupt treatment, the virus rebounds within a few weeks, usually 2 to 3 weeks. And the reason for this is because you have immune cells that harbor a latent HIV infection that we call the reservoir that are circulating, and these are long-lived cells that are really difficult to eradicate, and this is why the virus rebound. And that, generally speaking, 2 ways that scientists have been thinking about how to get rid of the reservoir. One is through gene editing mechanisms, such as bone marrow transplants, and this approach has actually led to eradication of HIV or cure of HIV in a few cases. But these are very expensive procedures, and in fact, the people who have had to undergo these procedures are people who had cancer and therefore needed a bone marrow transplant to cure their cancer. It was really not to cure HIV. So this is not likely to be a public health strategy that we can use for the majority of people. But there is good news, a little bit of good news, in the sense that combined therapy followed by immunotherapy have been shown to lead to variable remission in some people. So the idea here is that you put somebody on antiretroviral therapy for a time, and then you reduce the size of the reservoir, and then you also boost the immune responses. So the immune responses, whether they are NK cells, cytotoxic T cells, or antibodies, then control viremia durably for a long time. So the person is not really cured of HIV, but they can live without antiretroviral therapy. And this approach has been shown to work when ART was initiated during acute HIV infection. So we thought that this was a strategy that we could try in our setting. And we had a cohort, I would say almost the perfect cohort to do this kind of work. Because in 2012, we established a cohort that we call the FRESH cohort. In this cohort, what we do is that we follow women longitudinally who are at risk of HIV acquisition. And we bring them to the clinic. We test them twice a week with RNA testing. So if somebody becomes HIV positive, we will know immediately because when they come into the study in the beginning, they are HIV negative. The first 14 individuals that we identified with acute HIV infection were not put on immediate antiretroviral therapy because we were following the South African treatment guidelines at the time, which called for the initiation of ART when the CD4 counts fell below 350. But subsequently, we have been able to treat everybody that acquires HIV infection, and we start antiretroviral therapy within a day. And we were able to collect samples. These are blood samples, gut biopsies, lymph nodes from some of the participants. And more recently, we have also been able to do clinical trials and have these clinical trial samples. So this is the summary of the acute infections that we have been able to detect since we started this study. As of March 2025, we had 109 individuals that became acutely infected. And 14 of them, as I mentioned earlier, did not start treatment immediately, but subsequently everybody has started treatment immediately except for one individual who declined treatment. So what have we learned from this cohort of acute HIV infection? This is published data we showed many years ago now that when you treat during acute HIV infection, you blunted peak viremia, and this is shown in the red and blue lines here, where you can see that the viremia is much lower than compared to the people shown on the black line who did not start treatment immediately. And in fact, if you looked at the peak viremia that we could detect in the individuals who were untreated compared to those who went on to immediate treatment, you can see that those who went on to treatment immediately have much lower peak viremia. Similarly, if you looked at CD4 T cell counts, we could show that for the people who were not treated immediately, that their CD4 counts decline to a nadir, and then they have a recovery in the CD4 T cell count, but the CD4 counts never go back to what they were before infection in these individuals who did not start treatment immediately. This is in contrast to the individuals who started treatment immediately, where you can see that although they do also experience a nadir CD4 count, the CD4 counts do fall significantly after infection, they recover to levels that they were before infection. So this tells us that early treatment preserves CD4 T cell counts. And again, we were able to describe that these very early treated individuals did not seroconvert. Shown here are the first 14 individuals, and the blue dots represent a negative Western blot test. The red dots represent a positive Western blot test. You can see that the first 14 individuals invariably seroconverted, but for the people who started treatment in acute HIV infection, most of them actually do not seroconvert. This cohort has allowed us to then characterize the reservoir, which is this HIV that hides in immune cells. in people who started treatment during acute versus chronic HIV infection. And I'm going to show just a little bit of this data. Here, I'm showing the peak viremia, which I had already told you that the peak viremia is lower in the individuals who start treatment during acute HIV infection. They don't reach peak viremia. However, if we took blood samples at exactly the same time points as when we measured the viral load, the peak viral load, and measured the total DNA within immune cells, PBMCs, we don't see a significant difference in the total peak DNA. And this tells us that early treatment does not blunt the seeding of the reservoir. And this is possibly because treatment is actually is already too late to really impact at least the size of the reservoir, because the virus has really disseminated all over the body. This does not mean that early treatment is not beneficial, because in fact, when you subsequently follow individuals who started treatment in chronic HIV infection and compare them to those who started treatment in acute HIV infection, and you compare the size of their reservoir 1 year after they started treatment, you can show that the individuals with acute treated HIV have a much lower reservoir. And this tells us that the reservoir decay in these acute treated individuals is probably faster compared to the individuals who start treatment in chronic HIV infection. The other thing that this cohort has allowed us to do is to identify broadly neutralizing antibodies that are able to inhibit the transmitted founder viruses that these individuals have. And this is important, particularly for the individuals who start treatment during acute HIV infection, because this has allowed us to identify broadly neutralizing antibodies that would be the best candidates potentially for a curative intervention, because broadly neutralizing antibodies have been shown to, at least in some cases, lead to some control of viremia, ART-free control of viremia. And so we identified these two broadly neutralizing antibodies, VRC07 and CAP256, as the best broadly neutralizing antibodies that could be used to inhibit the transmitted founder viruses in the fresh cohort. I have shortcutted sort of the data on cytotoxic T-cell immune responses, but I just wanted to mention that these individuals, even the ones who start treatment early, they do develop cytotoxic T-cell immune responses, and we have been able to sequence the reservoir within immune cells in these individuals who start treatment in chronic versus acute HIV infection. So what I'm showing you here is one individual who started treatment in chronic phase of infection, and you can see that the virus is wild-type virus, mostly wild-type at the time that, of the transmission of the virus. However, as this individual moves into chronic phase of infection, they begin to accumulate immune escape variants. And these are represented here by the red bars. Now, here is another individual who started treatment in chronic HIV infection. And what we have now done here is sequenced the virus within the reservoir after this person goes on antiretroviral therapy. And again, what you see is that most of the virus within the reservoir is escape variants within the reservoir and not the wild-type virus. And this is in contrast to somebody who started treatment in acute HIV infection, where you can see that most of the virus that goes into the reservoir for this individual who started treatment in acute HIV infection is in fact wild-type virus. And this tells us that it actually might be better or easier, let me put it that way, it might be easier to mount an effective cytotoxic T-cell immune response in these individuals who started treatment in acute HIV infection, because their virus within the reservoir is the wild-type virus, which is likely to be targeted by cytotoxic T cells, whereas the virus for the people who start treatment in chronic HIV infection is mostly variant viruses, and this virus has already escaped from immune responses and may not therefore be targeted by immune responses. So to summarize on this part, we found that treatment of hyperacute infection blunts peak viremia and preserves CD4 T cells. Treatment during hyperacute infection did not blunt the proviral load, that's a baseline viremia, although it led to a faster decay of the reservoir. And we also found that early treatment reduced the reservoir size and complexity over time and preserves antiviral immune responses. So this work then led us to ask whether we could in fact intervene in these individuals who started treatment very early because they have these immunological as well as virologic advantages. And so we decided to evaluate the two broadly neutralizing antibodies that we had tested and found to be quite effective against the transmitted founder virus. But we also wanted to boost the immune response with a toll-like receptor 7 agonist called vasotolamoid. And we then interrupted treatment to see whether there would be a virus rebound. So again, we wanted to do this in individuals who started treatment during acute HIV infection because we think that starting treatment in acute HIV infection, or at least very early, because you can't always obviously start treatment in acute HIV infection, but the earlier somebody starts antiretroviral treatment, probably the better the immune repertoire is going to be. And as I mentioned, we intervened with the two broadly neutralizing antibodies and an immunomodulatory agent, the toll-like receptor 7 agonist. And then we interrupted treatment and we monitored to see whether the virus would rebound. So the goal of this study was to see whether we could delay viral rebound compared to what has been reported for people who interrupt treatment without any immunological intervention. So this was the first HIV cure trial in Africa. And again, all the participants were drawn from the fresh cohort, and they all started treatment very, very early. This was the study design. It was a single-arm, open-label phase 2A study. The individuals that we enrolled had to be virally suppressed on ART for at least 12 months. They had to be sensitive to at least one of the two, or they had to have a virus. Their transmitted founder virus had to be sensitive to at least one of the two broadly neutralizing antibodies, that is CAP256 and VRC07. Initially, we wanted them to be sensitive to both antibodies, but we had trouble identifying participants displaying sensitivity to both antibodies. And basically what we did is that we gave them vasotolamoid. We gave up to 10 doses of vasotolamoid to boost immune responses. And after the first dose of vasotolamoid, we gave them the dual infusion of the BNAbs, VRC07 and CAP256. We then followed them up and we started an analytical treatment interruption to see whether the virus would rebound during what we are calling period 2 of the study. And then the ATI continued into period 3. Period 3 is when the antibodies are beginning to wane. And then if they continue to control, after period 3, we continued them on an optional analytical treatment interruption. But we also were open that if they wanted to go back onto treatment, we put them back on treatment. So the primary endpoint of this study was the proportion of participants with treatment emergent adverse events. So obviously it was a safety trial because it's the first time this regimen had been used in humans. And the secondary endpoint was time to viral rebound and time to resumption of ART after analytical treatment interruption. And we also studied the PK, the pharmacokinetics, and anti-drug antibodies for the BNAbs that we used in this trial. The ART restart criteria, this was a set point analytical treatment interruption. So we allowed the viral load of 1,000 for 8 consecutive weeks before we put the participants on treatment, because we wanted to see whether the individuals would be able to control viremia on their own. However, if the viral load went up above 100,000 copies, then we restarted the treatment. And we also checked for CD4 T cell counts, so that if the CD4 counts fell below 350, we would also start treatment, although we didn't have to restart anybody because of the CD4 counts falling below 350. Again, these are the baseline characteristics of the participants, and I wanted to highlight the fact that most of these individuals started treatment one day, a median of 1 day after detection of acute HIV infection. So this was very early. And these individuals had been on treatment continuously for almost 7 years. So they had very minimal exposure to the virus before starting ART, and they had been on treatment for a long time. Generally, the regimen was well tolerated, and we did not see any serious adverse events in the study. However, there were infusion-related reactions that were quite frequent in 90% of participants, but these were mostly mild in severity. These are the concentrations of the 2 broadly neutralizing antibodies that we used in the study. And again, just to walk you through it, period 1 is when we administered the BNAB. Period 2 is when we started the ATI, the analytical treatment interruption. And you can see that during period 2, the concentrations of the BNABs are above the therapeutic dose. So these antibodies should be able to suppress the virus during period 2, even without antiretroviral therapy. And the same thing with for CAP256. However, the antibodies begin to go below the therapeutic dose at period 3 of the study. So what were the outcomes, the virological outcomes of the study? So we saw 3 distinct patterns. One was a group of individuals who we are calling the early ART restart individuals. This was 7 out of 20 participants who had to restart treatment during period 2. Again, to remind you, period 2 is when we started the analytical treatment interruption, but we expect the antibody levels to be above the therapeutic dose. So despite the fact that these individuals had antibodies above the therapeutic dose, the virus still rebounded, and that was in 7 out of 20 participants. And then we had a second group of participants, again 7 out of 20, who we are calling the delayed ART restart participants. These participants had to restart treatment when the antibody levels started waning below the therapeutic dose. And then finally, we had another group of individuals that we are calling the late ART restart or post-treatment controllers. These are individuals who remained off antiretroviral therapy through 48 weeks of the study. They had at least 44 weeks of analytical treatment interruption without needing to go on antiretroviral therapy based on the criteria that we had set. And 4 out of 20 of these participants, that's 20%, remained off antiretroviral therapy through the end of the study, which was 55 weeks of analytical treatment interruption. And these 4 individuals, all of them opted to remain off antiretroviral therapy when the study ended in close monitoring, with the viral loads being monitored every week. Now, subsequently, one of these individuals has gone back on treatment, but the other 3 are still off antiretroviral therapy and are being monitored. And it's almost 3 years now since one of these participants interrupted treatment, and it's about, on average, almost about 2 years now since these individuals stopped antiretroviral therapy. The other way to look at this data is to look at the rebound kinetics, the viral rebound kinetics. And again, what we saw is that for 12 of 20 participants, that's 60%, they rebounded with an exponential growth of viremia. So the virus, once the viremia took off, it just continued to increase until the individual had to restart treatment, and because they met the ART restart criteria. But for 8 out of 20 participants at 40%, they displayed atypical dynamics where the viral load went up and then came down to undetectable or remained at low levels. But in most cases, almost all these individuals, in fact, controlled back to undetectable at some point. We did not see anybody who remained completely viremia free throughout the study. Everybody had at least a little bit of viremia, and then they controlled it to undetectable levels. So to conclude, this is the first in Africa HIV cure trial, and it demonstrates that these kinds of complex studies can be successfully conducted in resource-limited settings. We had a great partnership with the community, ourselves in academia, and of course, this study was also sponsored by a pharmaceutical company, so it was really multi-sector collaborators that worked together in order to execute this study. The study regimen of vasotalamide and these two broadly neutralizing antibodies, VRCO7 and CAP256, was well tolerated with no serious study-related treatment emergent adverse events reported. 20% of participants, that's 4 out of 20, achieved durable ART-free control, and 40% experienced atypical rebound dynamics of viremia. So while this regimen did not achieve the durable control in all participants, we have ongoing studies in the laboratory to try and understand the mechanisms through which some individuals were able to control, and also to understand whether there was any impact on immune responses and reservoir size. And we also have been doing a lot of social behavioral studies for these participants in this study, their partners, as well as their family members, that we hope will be very critical for shaping the design and implementation of HIV cure trials in diverse settings. So in summary, a combination immunotherapeutic intervention in women who studied ART in acute HIV infection led to durable free control in some individuals. The studies are ongoing to understand the underlying mechanisms, but this particular regimen will not be tested further because obviously we had only 20% success. We don't think that that's really good enough to test or take this further, but we are looking at the mechanism to see whether this may have led to a vaccinal effect with new CD4 or CD8 T-cell immune responses or humoral immune responses. We are also studying the reservoir dynamics and rebounding virus, as well as biomarkers that may help us to design better studies in the future. And I would like to just conclude by saying that community and public engagement are needed to support HIV cure research work, but also manage expectations. This study, since I first presented this data about a few months ago, I've had so many people inquiring about whether they could take this regimen. Obviously, it cannot be tested further because it wasn't good enough, but it just shows the level of interest, but also I think the need for us to continue to do this work so that we can develop solutions for the future. I have very many people to thank for, but particularly the study participants, the FRESH study team, the colleagues I work with at the Africa Health Research Institute and the HIV Pathogenesis Program at the University of KwaZulu-Natal, particularly Krista Dong, who led a lot of the clinical trial work here, and my colleagues at Gilead, and very many people, including people in my lab that are that are really the backbone of this work and then do a fantastic job. Thank you very much for your attention.
Great. Thank you very much, Thumbi. That was fantastic. The room is clapping. Maybe we can take two questions. Penny, since I cut you off last time. Yeah. Just...
Thank you. Hi, Thumbi. Can you hear me?
Yes, I can hear you.
That's beautiful. Congratulations. I mean, on this, especially the recent results on the 4 individuals and 3 now. So with prospects of the future work, are you considering checking what's unique about the 3 individuals who never got to rebound post-treatment, actually controllers? And and then the maybe a short brief question is, what's the, again, what does toll-like receptor 7, because BNAPs, I imagine they are actually neutralizing the virus, but what are the toll-like receptor 7 agonists doing in contributing towards control of viremia? Thank you.
Thank you very much, Penny. The 7 agonist has been shown to actually boost HIV-specific CD4 cells and HIV-specific CD8 T cells, as well as NK cells, and to promote viral control, better viral control by immune cells, antiviral immune cells. And that's why we used that particular agent. There was also some idea that it might also actually lead to latency reversal by activating CD4 T cells. So we didn't see any induction of viremia by the toll-like receptor 7 agonist, but we think that it might be activating antiviral cells like CD8 T cells and NK cells.